Our keynote was supposed to be delivered by Dr. Sania Nishtar, who is the founder and president of Heartfile, and she's a very renowned speaker and an expert in health management and policy in Pakistan, represents the country in international conferences, and is running her own NGO. She was supposed to be here, and she just called 2 days back that there was a conflict in her schedule. She is from Khyber Medical College, and they were organizing an event in honor of her, which she had missed out, and so she requested me to go to her alma mater, and she has sent her recorded video. So we'll go with that. Dr. Sania Nishtar, can we have her video on?
Ladies and gentlemen, I deeply regret my inability to be here today for reasons that I have shared with the organizers, and I'd like to thank them for their understanding in this matter. I would also like to take this opportunity to congratulate the organizers and commend them on their efforts to organize this meeting, particularly for highlighting the critical role of technology in mainstreaming quality in the healthcare sector. I'm sure you all agree with me when I say that Pakistan's health system is in dire need of improvement. There have been many indications of poor health systems performance over the last decade. As a country, we are off track in meeting the Health Millennium Development Goals. There has been a consistent failure to meet stipulated targets within the health sector. And more recently, there have been some very ominous indications. As a country, we have been unable to eradicate polio, and as such, we jeopardize worldwide efforts to eradicate a disease from this planet for the second time. In 2009, Pakistan's underreporting of H1N1 was actually a proxy indicator for some critical weaknesses at the health information level. If you look at the three standard yardsticks for health systems performance assessment, which are fairness in financing, responsiveness, and equity in health outcomes, you will be able to appreciate that as a country, we underperform with respect to all these three indicators. There are certain determinants of poor health systems performance in Pakistan's mixed health system. I'm sure you'll all agree with me when I say that Pakistan's health system is mixed. There is coexistence of government-funded public service delivery along with market provision of services in an environment where out-of-pocket payments are a major means of health financing. And in this particular environment, there is an interplay of three determinants, which I have attempted to describe in my recent book. These three determinants are poor public financing for health, an unregulated burgeoning role of the private sector, and lack of transparency in governance. And these three factors interplay to undermine the quality and equity objectives of the health system in a very complicated manner. In this environment, there are certain entry points to reform. You can use service delivery as an entry point to reform. There could be a number of approaches to financing to reform mixed health systems, as can governance interventions be and human resource restructuring arrangements be. And most importantly, technology is one of the entry points to reform, which is why I think that the role of the organizers in highlighting this important entry point to reform is highly commendable. Technology as such, as you would appreciate, brings significant value to many health systems domains. It can improve efficiency, it can control costs, it can reduce human errors within the medical domain. It can enable and facilitate the delivery of new services. It can, most importantly, improve connectivity within the healthcare system. It can also assist with minimizing leakages and pilferages from the health system, and in that respect, it can help to promote transparency and accountability within the system. Appropriate use of technology can also help revolutionize learning, continuing medical education, and information dissemination, which, as you know, are critical elements of any health system. Technology, I would imagine, has a specific niche in Pakistan's health system, and for that matter in all sectors, because Pakistan has a distinct advantage. Its telecommunication infrastructure compares favorably with many developing countries, and in particular the use of mobile phone is very pervasive. It has expanded at a very rapid pace. There are over 90 million mobile phone subscribers in the country today, and enhanced connectivity and this infrastructure of mobile telephones which exists today can be used in ways to bring about changes in the system to improve social outcomes in the country. And today in particular, I'm going to talk about a health financing project that our organization has rolled out over the last year. It's called Heartfile Health Financing, and I'd like to thank the organizers for inviting me to speak about this. The scope of this project is social protection in health, and if I had the pleasure of being with you in person today, I would have showed you a number of different illustrations and slides to elaborate on this. But in the absence of that, I will be a little constrained. But to quickly recap what this project is about, let me tell you that the objective is to provide financial assistance to help poor patients who cannot afford to pay for health care and protecting them against the risk of medical impoverishment. We felt that there was a dire need for this project because more than 60% people in the country pay out of pocket for health care. They just do not have the means of paying for high-cost treatment. It is commonplace that they spend catastrophically, become indebted, and are pushed into the medical poverty trap. Many also forgo treatment, and statistics within the country show us that healthcare costs are the most common cause of economic shocks faced by poor households in the country. This is actually quite shocking because in a rural agrarian economy where agricultural and climatic shocks are commonplace, that people should report that healthcare shocks are one of the most commonest economic shocks faced by them. As opposed to the pervasiveness of this problem, there are limited windows of opportunity to help such patients because the government and civil society continues to prioritize primary health care. The system enables poor patients and doctors to seek financial help for patients who run the risk of spending catastrophically on health care in an expedient and transparent manner. The system has three components. One of them is a technology platform. The other is a system of validating poverty and prioritizing patients. And the third is a health equity funds. The way it works is that patients in need and their attending doctors in pre-registered hospitals can send requests for assistance through multiple channels to Heartfile Health Financing. Ideally, it is through an SMS on template and web interface, but it can also be through a fax, a telephone, and a letter. We subsequently ascertain poverty and their eligibility status by triangulating information from the doctors and the volunteers assessment. Volunteers are actually people who we send out to the field to conduct assessments on our behalf, and many of them conduct assessments through telemedicine, and then those data are transferred back to us. We subsequently have a mechanism for online validation of poverty. Heartfile is the only NGO with an online interface with the National Database Registration Authority, which is popularly known as NADRA. Once we send them the information, they validate the poverty status through a number of proxy indicators which have been developed for their BISP program, and they relay the information back to us within 15 minutes. Eligible cases are then supported through the Health Equity Fund, which is currently maintained by philanthropic contributions. And as an incentive to doctors to use the system, particularly as an incentive for them to use mobile SMSs as opposed to calling us, we transfer credits to doctors who use the system. There are a number of features which are unique to this program, and I'd like to share those with you very briefly. Firstly, this is an innovation in health financing which enables a country to increase the base of pooling for health. And it is an innovation in health financing which is of relevance to the informal sector. I'm sure you'll agree with me that insurance works best for the formally employed sector because of the opportunity to levy payroll taxes. And when a country has a predominance of people in the informal sector, the country does not have an option to levy payroll taxes, and governments actually have to make a per capita contribution for patients as such. And when there are resource constraints of the kind that we see in Pakistan, this option becomes very difficult. So for the informal sector, the model that we've developed is one approach to pool for financial risk protection. Secondly, through this program, we have a user-friendly integration of mHealth with a web-based interface, which enables us to process requests efficiently and monitor service delivery at several levels. Thirdly, we have a number of innovations in donation management which empower donors and make fund management transparent by enabling real-time viewing of micro-transaction details. And in fact, when we were planning this technology, we reached out to a number of international actors who worked in this space, and we found out that the level of transparency that was our requirement could not be provided to us through an off-the-shelf solution, which is why the technology had to be commissioned from scratch. Fourthly, the system has an ability to determine eligibility and has the ability to categorize patients based on pre-configured rules. And that feature enables us to guard against abuse. I'm sure many of you would know that the analogous of what we have developed from our organizational base is what is called Baitul Mal in the government system. And in that particular system, there's a high level of abuse and a high level of discretionary targeting of resources. And through the technology-based features that we have integrated into the system, one of the primary objectives that we hope to achieve is to eliminate this feature of arbitrariness and discretionary powers and abuse at several levels. And of course, by way of innovations, we also feel that we are strategically harnessing philanthropy to pool resources for health, where, as you will appreciate, there has been a significant gap. Let me also outline at this particular point that this system has a strategic significance for Pakistan. The country is undergoing very turbulent times. There's a dire need to broaden social protection systems in Pakistan in view of increasing poverty trends. Comparable state channels, Baitul Mal I've just referred to, process requests with delay. There are additional problems of abuse and patronage and targeting. And this system has been designed to overcome these problems. And although it is used presently for health, the system can be used for targeting social protection assistance as a broader social protection tool. So it can be used for cash transfers in disasters, for instance, or for educational stipends, or for income support, or whatever. Although we are using this instrument and tool to expand the base of the operations horizontally, and we will continue to run it from our organizational base at Heartfile, we hope that at some point there would be a vertical integration of this model that we've developed into policy, and that the state channels will institutionalize it. Let me at this point also reiterate that the technology infrastructure has been created with scale-up as a major consideration. Pakistan's telecommunication infrastructure, as I've already mentioned, and as you know better than me, allows deployment of such a tool even in the remotest area. The telemedicine for assessments and mHealth features, which we've integrated within this particular model, will allow upscaling with lean operational costs and without the need for extensive field operations. We also feel that in addition to Pakistan, this program has relevance for other developing countries, because health impoverishment is pervasive in the developing countries. More than 100 million people become impoverished, and a further 150 million face severe financial hardships as a result of healthcare payments globally. And most mixed health systems in developing countries face problems similar to Pakistan. So access to financial services has been termed as one of the 3 impediments to seeking healthcare in WHO's World Health Report on Health Financing in 2010. And we hope that the model that we have developed in Pakistan will be of relevance to many other countries as well. We have already developed international collaborations and are actively attempting to share our experiences even at this very early stage with various development entities who might be interested in sharing our experience. We have presented the pilot at the ECOSOC meeting in Geneva in 2009. We had a special session at the first Global Symposium on Health Systems Research in 2010, and we've presented this at the mHealth Summit in Washington last year. I would like to say very humbly that we've already published the proof of concept paper. It was selected as one of the background models to be showcased and to base the World Health Report 2010 on. That proof of concept paper is available online. Through our linkages with the Clinton Global Initiative, since this project is a joint commitment, we hope to further expand the base of our collaborations. We have certain plans for upscaling. For instance, in the sphere of technology, which is what we'd like to share with you, although we have plans for scaling up the Health Equity Fund, we have plans for honing further the poverty validation tools, but in terms of technology, which is what would be relevant to share with you at this conference, we'd like to integrate M-Money to enable cash transfers to poor patients. And that is now possible because the state bank regulations allow that, and the banking infrastructure for that has already been enabled. Secondly, we'd like to integrate business intelligence features to empower users of the system. And then we would like to integrate an in-kind items disbursement interface with this model, because right now the model is based on providing assistance to patients on an individual basis, and we hope to be able to deal with in-kind donation disbursement institutionally as well. We also have plans to deploy a capacity building program to build a critical mass of volunteers who are needed for program scale up. In addition, a longitudinal follow-up of patients is also planned to assess impact on mortality, morbidity, and poverty reduction endpoints. We are also planning to integrate a savings and M-credit module into the system, and then of course, as I already said, there is a planning stream that is focused on ascertaining how the base of the Health Equity Fund can be built. Let me tell you what a privilege it has been for me to have time to talk about this program. It's a critically important program since it brings tangible benefits to the lives of poor people, and we would really like to seek your help and partnership in expanding this. You can help and get involved by becoming a volunteer. You can help by enrolling your hospital and clinic, or you can make a donation through the system, or you could help us by disseminating this word. We look forward to keeping you updated about progress, and I'd like to thank you again for giving me this opportunity to speak about this program here. Thank you.